Good morning and welcome everyone. This is Ryan Green of Brand Asset Management Group. I want to thank you all today for joining us for our third annual Medicare Update webinar. You know, Medicare continues to be the primary healthcare solution for the vast majority of people age 65 and over, but very few people understand it, certainly not in its entirety. It's very complicated, confusing, it can be overwhelming. But finding that right solution is not only important to make sure that you do have the right coverage when you need it, but finding the right solution can also save you a meaningful amount of money if you do it right. Well, unfortunately, doing that isn't always easy, as the right solution can depend heavily on where you live, what doctors you like to see, and what medications you take. That's where our friend Karl comes in. Karl's an agent with Steinlage Insurance Agency, and he's a Medicare expert that many of our clients have found value working with over the years. I even sent my parents to him last year, so you know what I think of him. He's joined us today to talk about what you need to know for Medicare in 2018. But before we get started, I should note that you'll have the opportunity to ask questions. If you look on your screen, you should see a control bar there that'll have a box where you can type in your questions. We'll record them, and then we'll circle back to address them towards the end of the presentation. I should also note that following the presentation, we'll get an email sent out, and in that email, you'll find copies of today's slide. You'll also see Karl's contact information in that email, and then there'll also be a link for today's recorded session, so if you or anybody else you know that might be interested can circle back later on and listen to today's webinar. Now, with all that out of the way, I'll go ahead and hand it over to Karl Steinlage.
Good morning, everyone, and thank you for attending our third annual webinar. And without further ado, let's jump into it. So I often get asked, living in St. Louis and talking with clients all over the country, if we can help people outside of Missouri, and the short answer is absolutely. While Medicare is very comprehensive, very open, and very confusing, it is actually a very similar product, similar conversation, and similar policies that people can purchase across different states. So today we're licensed in the following states with the opportunity and ability to get licensed in really every state. It's a very simple process. So if you are not in one of the green shaded states but have questions or have family or friends outside of our current licensed states, I am definitely able and willing to help them, and it is a very simple process to do so. So Medicare has two basic components called Medicare Part A and Part B. Part A is free, and Part B is premium-based. And that premium is based off of a couple of different factors. One is your income. One is whether there is a cost of living adjustment in the Social Security benefit, and how long you've been on Medicare. The last couple of years, we haven't had much, if any, of a cost of living adjustment for Social Security, and that has got us into a kind of a unique situation where there's currently 3 levels of Medicare premiums, and the vast majority of people are paying the $109 a month. And this is the base amount for Medicare Part B, which can change every year. So there's been a lot of talk about a cost of living increase for Social Security, somewhere in the neighborhood of 2%. And whether it's 1.75 or 2.2, ultimately, I believe what's going to happen is with such a large increase that there's going to be more wiggle room for the Medicare premiums, and we're going to see a stabilization of the 3 different Medicare premium levels. So people who are paying the $109, which is most people who have been on Medicare for a number of years and drawing Social Security, the middle bracket of 121 and the higher bracket of 134 are the newer to Medicare people, so people maybe in their mid to late 60s. When this cost of living adjustment is announced, what we're going to see is a stabilization of all 3 of these premiums coming to the middle ground, probably in the $125 to $130 a month range. And so you're going to see the large group of people paying the $109 who haven't had Medicare Part B premium increases the last couple of years, or modest increases, are going to pick up some of that slack with their 2% cost of living adjustment. And then the people who are not drawing Social Security, or the people who are new to Medicare, have been paying a little bit more, are going to have possibly a reduction in premium. All of this information is still unknown, but is quickly coming to fruition, and typically we find out exactly what these numbers are sometime around mid-November, around Thanksgiving. So in addition to that base Medicare premium of $134 a month, if you're getting onto Medicare for the first time, looking at retiring or aging into Medicare, and it's important to note that Medicare is available to you the first day of the month you turn 65. So if your birthday is, say, February of 1953, then your Medicare benefits will begin on February 1st, 2018. A lot of clients that I work with will have working income above a certain threshold, which is $85,000 for a single person and $170,000 for a married couple. And Medicare now has an income adjustment called IRMA, which stands for Income Related Medicare Adjusted Amount. That is more or less a additional fee or additional premiums that you pay because of your income. And you can see on the screen the different brackets. These are per person premiums. So if a husband and wife had adjusted gross income of $300,000, they would each be asked to pay about an additional $130 a month for their Part B premium, and then an additional $34 a month for their prescription drug plan. It's important to note that the income uses a 2-year look back. And what I find is that a lot of people are in a situation where their working income is above the threshold. So maybe you were at $300,000 while you were working, or maybe you had an inheritance or liquidated stocks or business transactions where this income is a one-time event. And Medicare and Social Security actually allow you to appeal that income adjustment. And if you hit on one of the common reasons, which are shown below, the common qualifying events like a work stoppage, a retirement, you have a pretty good success rate in getting that income adjustment appealed. Pretty straightforward process. It's something that I help clients with. I know Ryan and I have talked with a couple of shared clients as well on how we go about just documenting that and walking you through that process. So if that's something that maybe will affect you this year because your 2016 income was higher than your 2015 and 2017 income, please reach out to us and we'd be happy to kind of coach you on that process. The income adjustment is also a variable number into the future, meaning that if you don't appeal it or your income changes from one year to the next, the Medicare premium is automatically adjusted in that 2-year interval. So in 2018, if your premium was lower or your income was lower, then in 2020, the Medicare premium would automatically reduce. So that appeal process kind of speeds up that reduction in premium. So on to possibly the biggest news, and I hit on this in last year's webinar, and hopefully this is not totally out of left field, but for the longest time, Medicare has used your Social Security number or a spouse's Social Security number as the identification number and billing number on your Medicare card. And finally, Medicare is getting up to speed and is removing the Medicare or the Social Security number as the claim number. And starting April of 2018, everybody in the country will be getting a new Medicare card. And on your screen is what it looks like. They're replacing the Social Security number with a unique random 11-digit number, and all Medicare cards will be replaced. A very good idea is to make sure that your mailing address and all of your contact information is current so the card gets to the right spot. You can see a couple of points of reference on how to confirm your address or update your address. Obviously, if you've been on Medicare for a number of years and you've been getting Medicare explanation of benefits and the the Medicare in You guide, which is that white year-to-year book, then they have your address correct. But if you've moved recently or you've been using dual residences, it might not be a bad idea just to make sure that everything is correct with the Social Security Department and Medicare. So what's the timeline look like? People who are turning 65 in April 2018 and on will actually only get the new Medicare card. They will not get the old card, which is a red, white, and blue card that had your Social Security number on it. After that, Medicare will start mailing the new cards in random geographic areas, which I thought was interesting. And as I was reading about this, the reason was that they didn't want people who were using this opportunity to fraud and scam people to kind of follow the paper trail of, think of starting in the top left-hand side of the map and then working down the West Coast and kind of just following that. So the government decided that if we just randomize where we're sending them to, it'll be a lot harder to trace. And I think the big point of today is to make people aware of this, especially people who have been on Medicare for a number of years. You're much more accustomed to showing that card, or maybe not even showing the card because you've seen the same doctors forever and they already know what your Medicare number is, but this is something that's affecting everybody and will occur here shortly. So key point is there's nothing that you need to do. Medicare will automatically mail you the card, and over the next year from 2018 to 2019 you can use both cards. But after 2020, only the new card will be usable. Once you get your new card, you're also supposed to destroy your old card and just start using the new card. So keep an eye out in your mailbox. Husband and wives should be getting the card in the same batch. So if one spouse gets it and a couple of weeks or a month or two has passed and the other spouse has not received their card, there may be some conflicting information or an updated address or something, or that might be a reason to call Social Security to inquire on the status of the card. So new Medicare cards coming April 2018. But no change in benefits, and it's important to note that this has nothing to do with the benefit offerings of Medicare. So this slide may look familiar for most people, but this is kind of your decision tree of Medicare, because Medicare is a great base, but it's really not enough to complete the package. And that's what all of these different private insurance companies like United Healthcare and Aetna and Blue Cross and Blue Shield are all offering supplemental or prescription drug plans or something called Medicare Advantage to help complete the package. And that's where our agency, I think, does a great job of working with clients to make sure that they're in the most appropriate plan for their needs. And each person has specific requirements as far as medications and doctors, where you live. Those variables that Ryan mentioned earlier really come into play as far as what plans may be most appropriate for a specific person. But ultimately, people fall on either the left-hand side of the path or the right-hand side. And the left-hand side, I think, is where most of you listening today is Medicare Primary, which is your red, white, and blue card, plus a Medicare Supplement card, and then a standalone prescription drug plan. So on the left-hand side, when you go to see your doctor, you show your Medicare card and your supplemental card, and Medicare pays 80%, that supplement picks up the 20%. And we'll talk more about the differences between the different lettered plans like A, B, C, F, G, etc. And then you also have a standalone drug plan. Oftentimes those two policies are through separate insurance companies, and we'll talk about the ways that you can kind of make sure you're in the most appropriate spot. On the right-hand side is something called Medicare Advantage, or Part C of Medicare. And you can think of Medicare Advantage as combining everything together. So the way it works is a private insurance company contracts with the federal government to offer a person the Medicare benefits only. So in Medicare Advantage, you're using a private insurance company's card and you're following the rules, and the plan drives the boat, meaning that you have a specific network, you have copays, deductibles, hospitalization fees, etc., associated with your plan. And each region or each area offers different programs. So if you're traveling or you put a big emphasis on the openness of your program, a lot of times that's what turns people off towards Medicare Advantage. I find what a lot of people get confused on is the fact that Medicare Advantage plans, especially in the St. Louis area, a lot of them are zero premium plans. And you think of the mail, if you've got your, well, I guess mail probably hasn't come yet this morning, but in your mailbox, I'm sure today there will be some advertisements for all-in-one or zero premium plans. And the way that it works is the federal government actually pays these private companies somewhere around $10,000 per person per year to subsidize the program. So while they're not charging you any premium, you still have to pay your Medicare premium along with any income adjustment. But then the federal government is subsidizing the plan and allowing them to manage the Medicare program. So they pay the 80%, they being United or Blue Cross or whoever you purchase, and they pay the doctor the 80%, you pay the 20% in the form of copays, deductibles, 20% charges, those types of things. Typically, the only time that you can jump paths is during the annual enrollment period, which is October 15th through December 7th of every year. And one final note is if you're on Medicare Advantage, so if you're on the right-hand side and you now realize that maybe those network restrictions are an issue, you're seeing more doctors, you're getting in and out of the hospital, or the plan is starting to become expensive because you're having to pay the out-of-pocket costs. If you want to jump back to the left-hand side, you have to wait until the end of the year. And unless you have a qualifying event, like moving out of the service area or the plan terminates on you, you have to answer health questions to purchase the Medicare Supplement policy. So a lot of people don't realize that until it's too late, and they can get trapped or stuck in Medicare Advantage because their health doesn't allow them to purchase a Medicare Supplement plan. So here we are on the eve of the annual enrollment period, which starts on October 15th and runs through December 7th. And it's important to note that Medicare annual enrollment period only affects plans that cover prescriptions. So on the previous slide, you have Part D on a standalone basis on the left-hand side, but people also have Medigap or Medicare Supplement plans. And another point of confusion is people often think that I can only change my Medicare supplement during the annual enrollment period, and that is actually not true. People can purchase or change Medicare supplement plans at any time during the year because those plans do not cover prescriptions. The only thing that's subject to the annual enrollment period is Medicare Part D and Medicare Advantage plans that have prescription drug coverage included in the program. So you have this time frame. Everybody by now hopefully has received something called an annual notice of change, or ANOC, and that simply states what your plan did this year for 2017 and what it is going to do next year. And the goal is to make that easy to digest and understand, but given the number of ANOC documents that I've seen and the fact that they're a couple hundred pages long, I find that a lot of people mean well and find many other things that they would rather do other than reading through the annual notice of change. So if you don't do anything and you let it ride, you automatically re-enroll into your same program for next year. But if you find that there's a reason to change, and we'll talk about some of the common reasons why somebody might change, you have to make that plan decision between October 15th and December 7th, and then it begins the first of the following year. Medicare also uses kind of a last-in wins concept, meaning that if you purchase a new drug plan during October through December, then that kicks the other one out automatically. So it's supposed to be a seamless conversion from Aetna to United or United to Humana, where that new company notifies Medicare and then automatically drops off the other policy. So how do you shop plans? The simple answer would be to call me, but if you're a do-it-yourself person, Medicare has a free tool that anybody can use anywhere in the country, and it's called the Medicare Plan Finder. And I've done a couple of specific examples or scenarios in some of the previous webinars that we've done, so I'm not going to jump into greater detail or as much detail as I did in the last ones. The main thing to point out is that this will solve for each individual person, meaning that you can plug in your home zip code, you can plug in your specific list of medications, your preferred pharmacy, and the software does all of the math for you. So in Missouri this year, there are 24 standalone prescription drug plans that somebody on Medicare can buy. The lowest premium is through a company called Humana at $20 a month, and the highest premium is through Blue Cross and Blue Shield at about $155 a month. I always tell clients and people I talk with is that, you get what you pay for is true in everything other than Medicare Part D, because paying more doesn't necessarily get you more. And if you're very analytical like I am, sometimes it takes a while to finally admit that and acknowledge that. But Medicare Part D, I think, is just confusing by its design, and the insurance companies with these annual changes and the way that they offer their programs and make small changes each year, or muddy the water almost on purpose, to where we find that only about 25% of people are in the most appropriate plan or the lowest cost plan for their specific medications, but yet only about 15% of people all across the country change their plan from year to year. So I find that this is kind of the low-hanging fruit, where you have a great opportunity to save a lot of money, to have that consistency of making sure that your current medications are still covered by your plan. I think everybody listening has probably seen or had this happen to them, where one of their current medications was dropped and maybe you didn't realize it until it was too late. And the pharmacist after the first of the year has to be the bearer of bad news, saying, I'm sorry, that drug's not covered. It's $300 or $400 because your plan dropped it off of their list. Or, you know what, we're no longer in network with your plan, so you actually can't use Walgreens or you can't use CVS. So this tool is fantastic for catching some of those issues and either making you aware of them in advance so we can kind of plan, or the better solution I find is to just play the game with the companies, and that means moving from company A to B to C over the course of a few years, because it keeps that continuity in line where you can stay at the same pharmacy, keep your same medications, and not have those frustrations bite you at the pharmacy. So the Medicare Plan Finder is a fantastic tool anybody can use. I have a document that we can send you that has a request for your list of medications and some of the specific moving parts to help you figure out the appropriate plan. So if anybody would like, we can send that document out. If you're a current client of our agency, we email and mail those out every year proactively, asking for a list of people's or clients' medications, their preferred pharmacy, and we run this software for each client every year at no cost. Another thing that is changing and is continuing to change is Medicare Part D, whether you're on Medicare Advantage or a standalone drug plan, has this oddly named feature called the donut hole or coverage gap. And in other webinars, we went into great detail. The big point I would try to hit on is that the donut hole is actually closing and has been closing every year from 2010 until 2020. And the way that it closes is the benchmarks, or the bucket of money that is available to everyone, gets bigger over time. For example, last year each person got about $3,300 to spend before they hit the donut hole. In 2018, you'll get about $3,800 to spend. And as you can see from the chart, if a person enters or gets into the donut hole, they actually receive greater discounts. And going back to 2010, at that time, if a person entered the donut hole, they were responsible for 100% of their prescription drug costs. I find the biggest reason that people fall into the donut hole is insulin and breathing medications. So if you're on insulin or you're on breathing medications for COPD or for asthma, not that there's a silver bullet sitting out there with a plan that covers all of those, but we've seen a couple of companies actually offer brand name insulin like Lantus and Novolog and Humalog, a lot of the insulin alternatives with these flex pens that are very popular and handy. These companies have actually started to offer them on preferred generic tiers rather than brand name tiers, which means a much lower copay to you at the pharmacy and lower costs on your medication. So if you get in the donut hole, then your out-of-pocket expenses lower compared to some of the other plans. That's another great service that the Medicare.gov Plan Finder shows you, is it gives you a projection of when you'll enter the donut hole, how much you'll spend when you're in the donut hole, and whether or not you get out of the coverage gap. And we can use some kind of proactive measures to see if there are ways to keep you out of the donut hole or lower your drug costs by switching pharmacies or talking to a doctor about a generic or a branded equivalent, because a specific plan maybe covers that drug for much less. Another fantastic tool that is available for everybody, and this actually works for anybody in the country. This is not a Medicare specific product, but this is a coupon aggregator called GoodRx. They have an iPhone and Android app which you can actually just download for free. But what it is you type in the name of a medication, the dosage, the strength, and your zip code, and it will pop up with pre-negotiated coupons and pre-negotiated discounts that I find a lot of times are cheaper than what your copay is on a medication. So I was running a review for a client yesterday, and he sent me his prescription drug list, and we couldn't find a good fit, if you will, for a drug plan because he was on one specific medication. And he was on a drug called Loveza, which is a fish oil, a prescription strength fish oil. And when we ran it through the Medicare.gov website, every single plan had it for way higher than what he had been paying, and it just something wasn't fitting. So I thought, let's check GoodRx, and here you can see this is in the St. Louis area. These are all coupons that if you go to the green button, that's fine. It'll print off a coupon which you can actually text to yourself, email, or print off and bring it into the pharmacy, and the pharmacy has already agreed to charge people this price for this prescription. So in my client's case, if he was going to buy this specific drug through his Medicare plan, the monthly cost was going to be over $100 a month. And with this coupon, it saves him 30 or 40 bucks a month on his prescription. And now we can use the rest of his drugs to kind of pick out the most appropriate plan, because we kind of have a built-in buffer or built-in cost for this specific drug. We don't have to use it to maybe purchase a more expensive Part D plan than we need to, because we have it at a reasonable price. So GoodRx works with everybody. It works independently of any insurance. You can use it for pet medications, for kids. You can use it for some over-the-counter medications if you have to get a prescription on them, like prescription strength Claritin, and it's just a really good tool to use. Many people have heard of this before, so if this is new to you, it's definitely legitimate, and it has a great kind of spot on your phone, if you will, for the app. And you just never know if a doctor prescribes, those one-time medications like steroid creams or a prescription strength cough syrup, something like that. I find those are the medications that this works best for. What this is not going to work for are going to be the drugs that you see advertised on TV. The brand name heart medicines, the brand name insulins, the brand name breathing medications, because those are going to be $300 or $400 a month. With the coupon, you're going to be better off running those through your Medicare drug plan. But those expensive generics, like this is a generic version of Lovaza, and even through Medicare Part D, those copays are still over $100 on most of the plans. So that's where I find the GoodRx program saves people the most amount of money, and it's just a great tool to have in your back pocket. No cost. You don't have to give any information away as far as name, social, or anything. And on the iPhone or Android app, you actually can do it at point of sale. So if a doctor doctor writes a prescription out, you go to the pharmacy and they tell you it's $200 because you have a deductible on your Part D plan, or maybe that drug is just not covered very well. It's a tier 4 or a tier 5. Feel free to just pull out your phone, type in the prescription, and you might be pleasantly surprised and find that using the GoodRx app saves you a lot of money. They just scan the coupon code right on your phone and you're done. So great tool to use. Another big change for next year that we're seeing is Walgreens is no longer a preferred pharmacy for some of the most popular plans that people have had in previous years. One of the games I find that Medicare Part D plays is each year it looks like there are defined winners and losers as far as plans. Obviously the companies that have the lowest premiums are going to attract a lot of people, or companies that cover the most common high blood pressure and thyroid and cholesterol medications for low cost are going to be attractive for the consumers. But you also get pharmacies negotiating and doing deals behind closed doors that affect people, and often those deals mean having CVS, for example, as a preferred pharmacy, but now it's taken a step further to not only do we want to be preferred, but we want our biggest competitor to be non-preferred. And what happens is, as a consumer, if you go into Walgreens and you don't realize that Walgreens is no longer a preferred pharmacy, you'll pay higher copays. So I actually had a client, and I would imagine a lot of people are getting the same letter. This was a letter that was just sent out to one of my clients who was on a Medicare Part D plan that is still using Walgreens, so they're still in network, but they've moved from a preferred pharmacy at a $1 or $2 copay for generics to non-preferred. So those same drugs are now $10 and $15 a month. And if you're taking 5 or 7 common generic drugs, and all of those move from $1 or $2 to 10 or 15, that's an extra $1,000 a year out of pocket that you're paying. And most people don't catch that. They just, everything's gone up, and they just keep going to Walgreens and they just pay the extra $1,000. They maybe don't realize that if they switch to another preferred pharmacy, which is CVS, Walmart, Hy-Vee, regional players like Schnucks and Dierbergs in St. Louis sometimes are preferred, you get those copays for $1 or $2. Or in our review, what we would do is we would identify that in advance, and maybe the right solution is to not just keep you with Aetna or not keep you with SilverScript or Humana, Walmart. It's to just move you laterally from the $20 Humana plan to the $22 WellCare plan. And WellCare still has Walgreens preferred. So I find a lot of people would rather just show a new card to the same pharmacy, which is less work, it's more convenient, it's what you're accustomed to, rather than moving all of your medications from Walgreens to Walmart, or a place that doesn't have a drive-through, or you mean to do it and then it kind of just, you forget about it because we're all used to our routines, and you keep going to that same pharmacy and spend that extra money unnecessarily. So this was a big change for next year. Walgreens for the longest time had been kind of the 800-pound gorilla in this market, where they had pretty much the preferred contracts with all of the major companies, but now we're seeing a pretty significant change to Medicare pharmacy networks for 2018. So keep an eye out for that letter from Walgreens. If you get it, it's definitely worth looking at some of the other plans on the right-hand side of that chart. So that's Medicare Part D, and most people who have a standalone drug plan also have a Medicare supplement policy. And Medicare supplement plans are standardized policies, and they are these lettered plans A through N. I would imagine the vast majority of people listening right now have Plan F, Plan G, or maybe Plan N, because up until a couple of years ago, Plan F was really the gold standard. It was the policy that everybody purchased, everybody shopped for, insurance companies marketed, and it was really where the game was played. And the easiest way to explain Plan F to somebody is that it pays 100% of everything left behind by Medicare. And clients love it because it's such a great feeling to walk into any doctor, any hospital, something happens, you need a biopsy or a hospitalization, and the bills start flowing in and the charges, but ultimately you owe zero every single time. And so clients love that, and I have a number of clients who are on Plan F, but what's happening is in 2020, the government is closing the door on Plan F to new to Medicare people. So you're going to get these Medicare beneficiaries who are turning 65 in 2020, 21, etc. They will no longer be able to purchase Plan F, and the Medicare supplement plans are undergoing a little bit of a facelift, which is this chart here. In the grand scheme of things, the world really isn't changing much, but what we're seeing is a huge push, both rate-wise, insurance companies playing the game now with some of these different lettered plans, and a lot of clients and consumers are starting to become aware through research, marketing, conversations like this, where Plan G is identical to Plan F in every single way, except for something called the Medicare Part B deductible. So if you look on the Part G, Plan G chart, there's no check mark in the Part B deductible box, and the Medicare Part B deductible is $183 per person per year. So everything that a person loves about Plan F, they would love about Plan G. The freedom to pick any doctor, the comprehensiveness of having all of these different services provided at no cost, except for one time per calendar year, you have about a $200, $183 per person deductible that you have to meet. So what I'm seeing is that a lot of clients that have been on Medicare for a few years on Plan F are paying $200, $250 per person per month. They can move to a Plan G at $150 a month per person, save sometimes $600 to $1,000 a year, pay that $200 deductible. It's a great way to kind of reset the rate clock, where the rates are much more competitive, maybe closer to what you had been paying when you first turned 65 or 4, 5, 7 years ago. So I would really encourage people, if you've been on Medicare for a number of years, you're on Plan F, to look at Plan G. Plan N works very similar, where you have to pay that $183 deductible, but then you also have a copay at the doctor. And I find a lot of clients, they just like, you know what, I'll move to Plan G because I'll pay the deductible annually, but I don't want to hassle with the copay, or what if I get, sick and I have a lot of physical therapy visits. I don't want to have to pay $20 each time. And there's no wrong or right answer. I find a lot of times the Medicare supplement plans, because they are standardized policies, they're all universally accepted. So whether you have Plan G or F from AARP, Mutual of Omaha, Transamerica, they all operate and are accepted by any doctor that participates in Medicare, universally the same. So it's not like you're reinventing the wheel as far as changing where you can go or what services are covered, because Medicare on all of these supplemental plans is driving the boat or is in charge. So if Medicare doesn't approve a service like a root canal or long-term care, then the Medicare supplement policy is not going to pick up the 20% because Medicare didn't approve that charge. Another great thing for the Missouri residents listening is that Missouri has a law that lets people switch from one Medicare supplement to another on your anniversary date without answering any health questions at all. So a lot of people who have been on Medicare supplement plans are hesitant to change in fear of maybe rocking the boat, or what if I get turned down, or what if they cover me but they don't cover my pre-existing conditions or my upcoming physical. Well, in Missouri, you're allowed to switch from Plan F to G or F to N on your policy anniversary date without having to disclose any health history, and the new company has to take you, and they have to offer you their preferred non-smoker rate. It's a state-specific law called the Missouri Anniversary Law. Your anniversary date is often when you first turn 65. I find a lot of people, when they get onto Medicare, they do a lot of homework, they pick out a plan, but then they maybe don't review it as often as they should, which is where our services come into play. But most of the time, a person's anniversary date is their birth month, because Medicare starts the first day of the month you turn 65. A lot of times it's January 1st because maybe you made a plan change, or your retirement date after 65 oftentimes is just the first of the year. So if you worked past 65 and retired in June or July because you were a teacher, then maybe your Medicare effective date is July. That might be the same month that you bought the supplement. It's really easy for me to find out, or through a conversation kind of give you a best case scenario of, if you're on Plan F paying $250, here's the best rate for a Plan G or a Plan N, based off of your zip code, based off of your husband and wife with spousal discounts, or other rating factors. Each insurance company is a little bit different as far as where their sweet spots are geographically. So different states, different insurance companies are more competitive, and then at different age bands, insurance companies are just more competitive at different rates. For example, here's some sample rates for a 65 female in the greater St. Louis area. A company that's been really competitively priced in the younger ages for Plan G is Transamerica. But as you get up to age 80 and on, Transamerica really isn't as competitive as, say, Aetna or Blue Cross and Blue Shield. And I think that's kind of the value of working with an independent broker, is I do all the work for you. We go out, we just fact find and have a conversation up front, and then I do all the homework and kind of give you the best case scenario. And if it makes sense to consider switching or looking at, then we kind of figure it out and get together or have more in-depth conversations on why you should change, how the mechanics work, and then ultimately assist you every step of the way. So here's some sample rates with the Medicare supplement plans in our area. Very easy for me to generate rate quotes. Can do it in a couple of minutes. We have all the tools to be able to do that. So Medicare supplement plans, I think the big thing to hit on is that take a look at Plan G. If you have a Plan F, there's probably a pretty significant savings depending on what you're paying, your age, etc. And in Missouri, you can switch on your anniversary date without answering any health questions whatsoever. Another common question that I get is fear of a plan dropping you later on. And I find a lot of that fear comes from hearing an insurance company's name in the news and not really knowing what it's tied to. And Blue Cross and Blue Shield, this is maybe more so for people in the St. Louis area, Anthem, the parent company of Blue Cross, announced that they were leaving the Affordable Care Act. So the Affordable Care Act very much has not a lot or very little to do with Medicare. And when a company leaves the Affordable Care Act, like Aetna did last year, or United Healthcare did 2 years ago, or Blue Cross is doing this year, it really has no bearing or effect on their Medicare programs. So people, I get calls and emails from clients all the time that says, hey, I heard that Blue Cross is dropping out of Obamacare. Do I need to go switch my Medicare supplement? And the answer to that is absolutely not, because all Medicare supplement plans across the country are what are called guaranteed renewable for life. So what that means is as long as you pay the premium, and the premiums can and will increase with every company, that's just a fact of life. But as long as you pay that premium, those companies can never drop you. So even those older clients who are grandfathered into Plan F, and Plan F is no longer available for new to Medicare people, you can still keep Plan F. It's not like you're going to get a letter in the mail saying that you've been dropped or you have to do something. And that's one of the perks of Medicare Supplement Insurance, is that the benefits never change. They can never single you out for rate increases. They can never drop you off of the program. So just to shore up some of that confusion, when you see companies getting out of group business or the employer market or modifying what they're doing within the Affordable Care Act, it really has no bearing on their Medicare offerings whatsoever. So since you guys asked about the Affordable Care Act, I'll just make one comment on it. A niche opportunity, and this might be for some of the younger people listening or children, is that for higher earning individuals, single people making over about $45,000 a year, or spouses making over about $65,000 a year, the Affordable Care Act is a very frustrating world to deal in. Frustrating because rates are going up, companies are leaving, and networks are very limited. And there is a way that groups of one or two can exist. And an example I could give you is I worked with two high school friends who are now in their 50s. They retired from corporate America. They lost their coverage through COBRA and the employer. They have a side business of rehabbing properties. And it's just two friends and their spouses and their 5 or 7 children. And rather than going through the Affordable Care Act, we were able to create a group of 2. And the unique opportunity here is that when you create a group, you get access to the nationwide PPO networks, where you have access to 90–95% of doctors anywhere in the country. So this is a great opportunity, a great option for those early retirees or self-employed people who are not on Medicare yet, which starts at 65, but they're in that kind of no man's land where there's not a great option through the Affordable Care Act. If they have a business, whether it's an LLC partnership, there are ways that you can have a group of 1 where a financial advisor and a admin are on a group, something like that. So just to throw that out there, if you have children or anybody else who is rightfully frustrated with the Affordable Care Act, this may be a way to not solve all of their problems, but at least keep all of their doctors in network and give them a much more robust plan. So wrapping up, another benefit that many people have taken advantage of, and actually just got an email from somebody this morning from Brand on this, Cigna has a dental PPO plan that is legitimate major major dental insurance, which will cover very much like an employer plan, where it'll cover 100% for cleanings and x-rays. It will pay 80% for what they call basic services like an extraction or a cavity, and then 50% for major services like root canals, bridges, crowns, etc. And the unique thing about this product is that it is a PPO network, so any dentist in the country will get paid by it, but there's no waiting periods for major services. So a lot of people don't take dental, which is not covered by Medicare, so it's not covered by the supplement, because it's really not worth it. You know, you kind of do all the homework and you annualize what you're paying in premiums and compare it to what you get. A lot of people just self-insure. But when you have that major issue and you have to pay the $1,000 or $2,000, a great ace up your sleeve to have is to give us a call. We can sign you up for Cigna with no waiting period. So I've had clients who have had multiple issues, you know, things that they've kind of waited on because of the cost, and we just stack them all together, and you pay the $45 to Cigna for the 1 month, and you can get up to $1,500 per person per year of benefits at that 50% payment, and then you can drop it later on. So there's no lock-ins, there's no contracts you have to sign. It's just a nice way to kind of lessen the sting of the bad news you get at the dentist. So if anybody has any questions on that or wants literature, I always advise in a situation like that to bring the brochure and the document to the dentist and let them do some of the homework to give you a more accurate idea of what Cigna will pay, whether they're in or out of network, and then what you know, you'll end up owing, so that way there's no surprises. Continuing our wrap-up, I think overall, compared to previous years, Medicare benefits look very stable for next year. You're always going to have some modifications, you know, some very clear winners and losers as far as networks and, you know, what we talked about with Walgreens and, you know, Plan G, but very much no news is good news in the Medicare world. So I don't see a huge increase in Medicare premiums, which is always welcome. I don't see massive changes as far as rate adjustments for current Medicare supplement plans. So less volatility, continued rate stability, I think those are all good things to hear and kind of wrap up on. Other things that we hit on, consider Plan F or Plan G or Plan N over Plan F as a great way to save money without sacrificing benefits. And I would just encourage everybody to look at your prescriptions and make sure they're still covered by your current plan. Make sure that your preferred pharmacy is still in the plan's preferred network. Do those things now so you don't have that frustration and that bad experience at the pharmacy after the first of the year, because if you miss that December 7th cutoff, then it's too late to change. So thanks again for taking some time out this morning and listening. If anybody has any questions, I'd be happy to help answer them right now. If you have a specific question on your situation, always feel free to reach out, send me an email, give me a call. I'm happy to take 10 or 20 minutes out of my day to just give you some advice or maybe point you in the right direction as far as where you need to be. So thanks again.
And thank you, Karl. Great job. Good information. You know, this is the third go-round for this, and I continue to pick up new information every time. But the one theme I think that continues is that, man, this is just complicated stuff. And getting it wrong can cost a couple hundreds, if not thousands of dollars in any given year. And really, there's just no reason to go it alone when there's people like Karl out there offering the service that's offered. So strong encouragement there. Hey, you know, we kind of joke about it here in the office, but when we get questions from clients about Medicare, healthcare in general, our answer is almost always, I don't know, call Karl. So with that set aside,
I was just going to make one quick comment on what you said, and that it's not that there are bad plans within Medicare, because even the most expensive plan may have a time and place for somebody. So it's not that, you know, someone is in a, they may just be in the wrong plan for their needs, and this very much has turned into just matching people with the appropriate plans, and that's where that margin of, you know, moving from A to B saves you $1,000, but doing that same move for someone else with different medications in a different pharmacy might cost them $500 more than what they're paying. So it's just, I always joke I play a huge game of musical chairs at the end of the year where everyone's moving, and, you know, Marissa stands up and goes over there and Ryan stands up and goes over there, but it's all about matching the appropriate plan for their situation.
good clarification. So we do have a few questions here that we got come in, so I'll identify those and ask those now if that's all right. So one question we got is, if you turn 65 in June of 2018, so turn 65 next year, is there anything that needs to be done within this enrollment period, or do the necessary actions get delayed until June of next year?
Great question, because the marketing ramp up of when you turn 65 starts usually about 12 months in advance. So I'm sure you're getting conflicting information on what to do. But the correct answer is to just kind of keep your head in the sand until about 4 months before your 65th birthday. So assuming your birthday is not June 1st, because if it was June 1st and Medicare starts May 1, your target start date is June 1st, and you would really want to kind of dig in and, you know, identify what plans and what medications you're taking and do all that homework. Usually about, like, say March, February, March is really when you want to kind of start the process. You're going to be in that group where you get the new Medicare card only, so I would definitely jump into that a little bit earlier than normal, just because there's going to be a learning curve with that new Medicare card.
All right, so earlier on you mentioned changing on the anniversary date. How does someone find out what their anniversary date is if they don't know?
If you have your policy from 10 or 15 years ago, it'll show it on the schedule or declaration page, but I find a lot of people can't find the policy, which is understandable. So a lot of the Medicare supplement companies have online portals. I also find that a lot of people don't use or have created logins because it's really not necessary, because your plan pays 100%. Some companies have it on their card. So if you just look at your card that you show the doctor, a lot of times the lettered plan and the effective date is right there on the card. Another way would be to call the insurance company. So turn the card over and look on the back and just ask them when the original effective date is. If you do that in anticipation of switching, you might ask them to mail you a duplicate copy of your policy or a copy of your schedule or declaration page, which is just like the front document that shows what lettered plan you have, what the original effective date is, etc. Because if you do change on your anniversary date, while the companies can't ask any health questions, they do require you to show proof of your effective date, so that you would need documentation to show that to the new company regardless. Other ways, I think if it's been a number of years since you've been on Medicare, I would imagine more, and you haven't changed, your Medicare supplement effective date is probably the same as your Medicare Part B effective date. So if you look on the red, white, and blue Medicare card. And another thing to point out is that each company with this anniversary law is, or can be more or less liberal in what they allow and what documentation they require and how much of a time frame. So I'll give you an example. If your anniversary date for Plan F is January 1st, some companies say we will only let you have an effective date of January 1st. but other carriers actually give you a 60-day window left and right. So you could actually switch as early as November 1st or as late as February 1st with an effect, or March 1st, excuse me, with an effective date of January 1. But for you, it would be identify that effective date, give me a call, and probably calling the insurance company and asking them that specific question would be the best way.
All right. So what is the cost for using you, Karl, as a broker?
The best answer, nothing. My services are compensated by the insurance companies, and the commissions that they pay agents and brokers are actually built into the product. So Blue Cross or Aetna or whoever it might be, I made reference to that $20 Humana plan earlier. That plan is $20 a month no matter how you buy the policy, and using my services has absolutely no added cost or fees to you. There's no hourly charges that if you have a question or something, we get compensated by the insurance companies, and it costs you absolutely nothing.
That is the best answer. I think we have time for one more question here. I know we've gone just a couple of minutes over, but I do want to make sure that we get this last question out there. So the question is there a relationship between Social Security and being on it locks you into a Medicare premium as opposed to waiting to start Social Security and pay a higher Medicare premium later on?
So the question of should you draw Social Security now to lock in your Medicare premiums was kind of the basis of it. And to that, I would say there's really no major benefit in taking Social Security early to lock in your Medicare premium. If you think back to one of the previous slides, where right now there's 3 different groups, the 109, the 121, and the 134, it's pretty rare for us to have different groups of Medicare premiums. And I would say 90% of the time, Medicare's been around since 1960 or so. Up until now, only maybe 5 or 6 years have had staggered Medicare premiums. So I don't think there wouldn't be an incentive to take Social Security right now under the assumption that, I'll lock my Medicare premium in at a lower amount. If your income is above those brackets at $85,000 and the $170,000, you get hit with the highest Medicare premium and the full income adjustment whether you're on Social or not. So there's no way to kind of avoid that other than having income under those thresholds. And when we have a Social Security cost of living adjustment, like hopefully the 2%, that's going to bring everybody to a middle ground. Real quick, I think maybe you're referencing something called a hold harmless provision, which just means that a person's Social Security check can't decrease from one year to the next. So if you were paying $1,000 or getting, say, $1,000 a month in Social Security benefits, and your Medicare premium was $100, you take home $900 a month. If your Social doesn't rise, then your Medicare premium can't rise. But the person who's not on Social, their Medicare premium goes up more to offset that, and that's what we saw 2 years ago and then last year. But ultimately, when there's a cost of living adjustment that raises your Medicare or Social Security check by $20 or $30, a lot of that is going to go to just increase your Medicare premium. So short answer is no, I don't see a reason to jump into Social Security to lock in Medicare.
All right, we are just about out of time. Once again, thank you, Karl. We greatly appreciate you sharing your expertise here with us today. And thank you to all of you listening out there. If you have a question, we didn't get to answer it today, the contact information, as we said, you see it in the materials here. It'll be sent along with the follow-up email that goes out. Don't hesitate to reach out to Karl. We'd be more than happy to get you the answer. Again, watch out for that email coming. It's also going to have the slides from today, and it'll have a link to the recorded session. And then we're also going to provide that document Karl mentioned earlier in the presentation when he was talking about the medications and pharmacy network changes and that sort of thing. So once again, we're signing off. Thank you everyone for joining us. And again, please reach out to Karl with any additional questions you might have.